I'm Dr. Samir Patel, and I'll be talking about weight loss surgery. The first part of the talk will be talking about the medical implications of being overweight, then the surgical treatment of being overweight, and finally, what it's going to take to go from this room to the operating room. There's no love more sincere than a love for food. Patients who are overweight have excess energy that's stored in the form of fat, and this excess fat causes a whole host of medical problems. We don't understand why one person is normal weight or one person is overweight, but it's multifactorial. It's psychological, it's social, and it's genetic. The most important thing to really get out of this talk is to really understand how overweight you are, and that's best measured by your body mass index, which is your weight in kilograms over your height in meters squared. Well, how do you calculate that? In your packet, you're given a table. The table shows your weight is on the y-axis and your height is on the x-axis, and you come up with a number. That number is your body mass index. Well, what does that number really mean? You're considered normal weight when your body mass index is less than 25. You're considered overweight when your body mass index is between 25 to 29. You're considered obese when your body mass index is between 30 to 34. You're considered severely obese when your body mass index is from 35 to 39. And you're considered morbidly obese if your body mass index is 40 or greater. So 70% of Americans have a body mass index of greater than 25, making us overweight. And greater than 30% of us have a body mass index of greater than 30, making us obese. It's when your body mass index is greater than 35 are you considered a candidate for surgery. When your body mass index is between 35 to 39 with a medical problem, such as diabetes, high blood pressure, high cholesterol, sleep apnea, heart disease, or reflux disease, you're considered a candidate for surgery. Or if your body mass index is 40 or greater, even without a medical problem, you're still considered a candidate for surgery today, because studies have shown that even without a medical problem today, you are guaranteed to develop a medical problem in the future if your body mass index is 40 or greater, and you'll die from complications of all those medical problems in the future. So it's better to have surgery now before the medical problems set in. Compared to a person that's normal weight, a person that's overweight has 50 to 100% chance of dying prematurely. The heavier you are, the higher your body mass index is, the higher your chances are of dying prematurely. And at least 400,000 deaths per year are related to being overweight alone. So what sort of medical problems do overweight patients suffer from? I've mentioned those before. High blood pressure, sleep apnea, high heart disease, high cholesterol. You also develop issues with gallstones, and you also have increased chances of having certain types of cancer. So the heavier you are, the higher your body mass index is, the higher your chances are of dying prematurely, and this is where surgery comes into play. You also have a negative self-image about yourself, and everyday living becomes more and more difficult. So the first step to battling your weight is always going to be some sort of diet and exercise program, because the insurance companies like to know that you considered something else prior to considering surgery. So bring in documentation of the different types of diets that you tried and different types of exercise programs you've tried. Patients have also tried weight loss medications such as fen-phen in the past. There's phentermine that's present today, Saxenda, and there's multiple different types of other medications that are available for weight loss. If you tried them in the past, bring in documentation of that. But studies have shown that through diet and exercise alone, and even with medications, the best you can hope for is about 10% excess weight loss, which doesn't make a huge impact on your medical problems long term. Well, what does that mean? That means if you're 5'7" and your ideal body weight is 150 pounds, and you weigh 250 pounds, you have 100 pounds of excess weight. So through diet and exercise and medications, you're going to lose 10% of that 100 pounds, or only 10 pounds. Okay? Studies have shown that you need to lose at least 50% or more of your excess body weight to make a huge impact on your medical problems long term. And the only way to do that is with surgery. So again, surgery is not a cure-all. I always tell patients that in order to have success through surgery, it's basically 3 prongs: diet, exercise, and surgery. We will help you with the surgery, okay, and through our nutritionist, we're going to help you develop a diet and exercise program. Once you do all 3, you'll be happy, and the goal is for you to lose at least 50% or more of your excess body weight at the end of 1 year after surgery, and to continue that weight loss for at least another 10 years. So the goal is that whatever weight loss you maintain at the end of 1 year, we want you to maintain that weight loss without gaining any weight for another 10 years. So, what sort of options do we have for surgery? Well, there's two different types of options I'd like to discuss. The first type is a restrictive procedure. You basically reduce how much food your stomach holds. Right now, your stomach is the size of a football. Okay, by performing surgery such as the gastric sleeve, we're going to remove 85% of your stomach, and with the remaining 15% of your stomach, you'll be able to eat most foods, chicken, fish, vegetables. But you're going to basically be eating off of a plate about the size of the palm of your hand 3 times a day. Studies have shown that all you really need to eat is about 1,500 calories per day, and that includes 60 grams of protein. That breaks down about a saucer full of food 3 times a day. We mentally cannot eat a saucer full of food and feel full. That's where surgery comes into play. Right now, you're eating about 3,000 to 4,000 calories per day. Imagine eating at least half or 1/3 of what you're normally eating now. Okay? That in itself will cause hunger issues. With surgery, we're going to help alleviate some of those hunger issues by removing the hunger sensation from your body. How do we do that? Well, the first step is by performing the gastric sleeve. The gastric sleeve is a restrictive procedure. It reduces how much food the stomach can hold, and by doing that, we reduce the number of calories your body takes in. By going about your daily activities, you're going to burn off more calories than you take in, and the body makes up the difference of burning off the excess fat that's on your body. If you exercise, you're going to burn off a lot more than you take in, and you'll really have good weight loss that will continue for years to come. So, with the gastric sleeve, the way I perform the operation is that I place 5 small incisions on your belly. Each of them are about 1/4 of an inch, and one of them is about 1/2 an inch right above your belly button. And using those incisions, I place a camera inside your belly and I look around, and I put a special camera through your mouth into your stomach. So I have a camera looking inside your stomach, and I have a camera looking outside your stomach. And by performing surgery, by stapling and cutting your stomach, I basically change the shape of your stomach from a football-sized shape of your stomach to a banana-sized shape of your stomach. And basically, I remove that 85% of your stomach through an incision that's above your belly button. With that 15% of stomach that's left behind, you're going to basically eat about 1,200 calories per day, including 60 to 80 grams of protein in per day, and you won't become malnourished, you won't lose your hair, and you're going to be able to continue your normal life as you're losing weight and continue your journey on a healthy pathway. The other part of the procedure that will help your hunger sensation is that the top of your stomach is called the fundus, and it's right over here, and this produces a hormone called ghrelin, which produces hunger when your stomach is empty. By physically removing that hunger producing part of your stomach, we basically reduce that sensation of hunger after surgery, and basically by eating a small amount of food 3 times a day, you'll feel satisfied, you'll feel full, and will take away that hunger sensation. The complications of the sleeve are basically caused by the staple line that is 6 inches long. The first complication that you have to worry about is bleeding. In the United States, there's a 1% chance of bleeding after a sleeve gastrectomy that results in a blood transfusion. At AtlantiCare, it's 0.4%. The most common time to have bleeding with the sleeve gastrectomy is within the first 24 hours after surgery. So once you've had surgery, you get admitted to the hospital to a private room that's on the top floor of the AtlantiCare Regional Medical Center City Division. You'll have blood work done 6 hours after your procedure and then the morning after. As long as your hemoglobin is stable, we know that your risk of bleeding has resolved. The second complication you have to worry about are leaks. Leaks are defects in the staple line. They typically occur at the top of the staple line, and they can occur within the first month after surgery. The most common time that it can occur is 10 days after surgery, after you're discharged from the hospital. The second time that they can occur is 30 days after discharge from the hospital, and the least most common time that they will occur is within the first 24 hours after surgery. So typically, patients stay overnight for observation to make sure that there's no leaks or bleeding within the first 24 hours after the procedure. Then patients will see me in the office 10 days after the surgery and 30 days after the surgery, just to make sure that there's no complications after the procedure. Once you've passed your 30-day period after surgery, the risk of complications are almost zero after the gastric sleeve. The third complication with the gastric sleeve is gastroesophageal reflux disease. So if you have reflux disease before the operation, 17% of patients will result in worsening reflux after the operation. If you don't have any reflux symptoms now, again, you can develop reflux symptoms after the operation. If that occurs, we put you on a acid blocker pill once a day to help alleviate those symptoms. So the gastric sleeve is the most common operation for weight loss in the United States. It is being performed 50% of the time or more in the United States, and it is an operation that's done with 5 small incisions, and it results in an overnight stay in the hospital. Now, the second most common operation in the United States is the gastric bypass. Now, the gastric bypass is the operation that's been done the longest. It's been done since 1967, and it's been done laparoscopically since 1997. So with the gastric bypass, you can lose 55% or more of your excess body weight at the end of 1 year and maintain that weight loss for another 10 years. The operation is done through 6 small incisions, and initially the first step by performing the operation is we staple across the top part of your stomach, creating a very small pouch. Then we reroute the intestines to maintain continuity with the rest of the digestive tract. The intestine that connects the pouch to the rest of the intestinal tract is called the rulum. The part of the intestinal tract that drains the liver and the pancreas that contains all your digestive enzymes is called the biliopancreatic limb. When the rulum meets with the biliopancreatic limb, that one channel is called the common channel. That's where digestion occurs. So in the rulum, there's no digestive enzymes. So the small amount of food that you eat, you basically don't absorb any calories in that food until the digestive enzymes in the biliopancreatic limb meet with the food in the rulum in the common channel. And that's when the absorption of calories and vitamins occur. So this operation is known as a malabsorption operation because you're not really absorbing the calories until the food gets mixed in the common channel. So with this additional rerouting of the intestine, you get an additional 5% of weight loss. And this operation is a great operation. It's an operation we've been doing the longest. And typically, this operation are for patients who have severe reflux disease or have severe diabetes. Because studies have shown that just from the rerouting of the intestines, you increase your body's sensitivity to your native insulin, and patients who are diabetics will have their diabetes go into remission shortly after the gastric bypass. And again, the weight loss from the gastric bypass is 55% versus the sleeve. The leak rate is 1% for the sleeve and 1% for the gastric bypass, all from the staple line. And again, the staple line in the sleeve is one very long staple line versus the gastric bypass, which has 4 separate areas of a staple line. The other complication of the gastric bypass is something called an internal hernia, and that occurs about 1% of the time in patients several years after surgery. And what that is that there's a space behind the rulum. And the rulum is sitting on top of your stomach and your colon. And sometimes after weight loss, that space becomes more exaggerated, and you can have intestine go behind that rulum and twist your rulum. And that's called an internal hernia. If that occurs, I go in laparoscopically, untwist the intestines, and I basically try to put sutures in to obliterate that space behind the rulum. So those are the biggest complications of the gastric bypass short term. Long term, you have to worry about something called a marginal ulcer, and that's an ulcer in the intestine between the pouch and the small intestine rulin. The most common cause of marginal ulcers is smoking. Up to 2% of patients after the gastric bypass will develop a marginal ulcer, and the most common cause is smoking. If you're not a smoker, then the other causes of the marginal ulcer are the sutures and the staples that are used to create this anastomosis. Typically, if you're a smoker, I tell patients that you need to stop smoking at least 2 months before the procedure and to continue to stop smoking after the procedure, because the first step along your healthy journey is to stop smoking. Through surgery, diet, and exercise will help you continue along this pathway. So, with the gastric bypass, this operation has been around since 1967, and long-term results have shown that patients will lose 55% or more of their excess body weight at the end of 10 years. The gastric sleeve 10-year data has shown that you're going to lose 50% or more of your excess body weight and keep that weight off at 10 years. So the most common complication that you also have to worry about with the gastric bypass, and not so with the sleeve, is something called dumping. And dumping is if you decide to eat high-fat foods or high-starch foods, such as potato chips, French fries, ice cream. Those high-calorie, high-fat, high-sugar food will go into the rulum, and because the body cannot digest the high-fat, high-sugar content in those types of food, the body will dump water from your bloodstream into the rulum to help dilute out that high-fat, high-sugar content. By doing that, your body will cause you to go into having a rapid heartbeat. You're going to break out into a cold sweat. You may have some hand tremors, and you feel like you're having a heart attack. And after a couple of hours, it goes away. So I always tell patients that after gastric sleeve and after gastric bypass, you really need to avoid high-fat foods, high-calorie foods, high-sugar foods, because this will harm you and basically will prevent you from continuing on to your healthy journey. With the gastric bypass, because it is a bigger operation, the first day of the procedure, you're not allowed to drink or eat anything. The next day, I get an upper GI series just to document the fact that the anastomosis is perfect and there's no issues with the intestinal rerouting. And then I start you on a clear liquid diet and you go home the following day. With the gastric sleeve, because we test the sleeve during the procedure, you can start drinking right after the procedure. So you spend 1 night in the hospital with the gastric sleeve, 2 nights in the hospital with the gastric bypass. And the diet is very simple. The first 2 days after the procedure, you're on a clear liquid diet, jello and broth. And then from day 3 to day 10 after the procedure, you're on full liquids, yogurt, pudding, protein milkshakes. Then from day 11 to day 20, you're on soft foods such as eggs and fish. And then from day 20 to day 30, you basically progress yourself to a ground chicken, ground turkey meal onto soft regular food. And after that, you're basically eating 3 small meals a day of soft regular food, consisting mostly of chicken, fish, and vegetables. Carbohydrates after surgery will cause you to feel bloated. Carbohydrates are difficult to be digested by your gastric pouch or the gastric bypass or your gastric sleeve. So I always tell patients to try to avoid carbohydrates after surgery. If down the road you feel like having a small amount of rice or a small amount of bread, try to make sure you're eating flat bread and rice such as brown rice, which does not expand as much as white rice. The other thing that is different after surgery is that the gastric pouch is small and the gastric sleeve is small. So I always tell patients that if you decide to eat, try not to drink anything 1/2 hour before a meal or 1/2 hour after a meal. because the gastric pouch and the gastric sleeve can only fit food or liquid. It doesn't have space for both. So typically, if you decide to drink something, wait a half an hour before eating something, or if you decide to eat something, wait a half an hour before drinking something. If you drink too soon or eat too soon, you will feel nauseous and you will throw up. So the lifelong goals are for you to eat 3 small meals per day, take your vitamins daily, make sure you get at least 60 grams of protein in per day to maintain your body, and try to exercise on a daily basis. Initially, start off small, 30 minutes of walking per day. After surgery, that's going to help you on your healthy journey. As you increase your activity, as you lose weight, the more you exercise, the more calories you'll burn off, the faster you'll lose the weight and maintain that weight loss. So, how do you go from this room to the operating room? The first step is watching the webinar. Once you've done this, please make an appointment to see me in the office. Once I see you in the office, I will order some lab work and some radiological studies such as an upper GI series and a chest x-ray. And then I may have you see your primary care doctor, giving you clearance for surgery. If your body mass index is greater than 50, I may ask you to see a heart doctor and a lung doctor to make sure your body is safe and optimized for general anesthesia. Everybody has to see a psychologist and the nutritionist that's in the office. Once you've done this workup, we'll bring you back in, we'll review all the studies with you, and we'll give you a date for surgery. 1 week prior to surgery, you'll do an hour class that's educational about your surgery, and then you'll take a 20-question true-false test about the surgery of your choice. Once you pass the test, which is 80%, you'll have surgery the following week. Our program consists of a psychologist, a nutritionist, 2 physician assistants, 3 full-time surgeons, and surgical residents. So you will have 24-hour care, 7 days a week, whether you're in the office or at home or in the hospital. Thank you for watching the webinar. I'm Dr. Samir Patel, and I hope to see you soon. Thank you for choosing AtlantiCare.